Hello, my name's Mike Deeb. I'm from Michigan, and today I'd like to discuss the pursuit of the Holy Grail for aortic valve replacement, the perfect prosthesis-patient match. These are my disclosures. Well, in 1978, Shabuddin Rahimtoola published a series of 19 patients who underwent aortic valve replacement for severe aortic stenosis, congestive heart failure, and a reduced ejection fraction. Postoperatively, he found that these patients had improved survival, improved New York Heart Classification for congestive heart failure, and improved EF, while a markedly reduced low mean valvular gradient when compared to similarly matched medical patients. Because of this, he declared that patients with severe aortic stenosis and congestive heart failure should undergo aortic valve replacement. He also introduced the concept of patient prosthesis mismatch. That's when the opening area of the prosthetic valve that's implanted is not equal to the normal opening area of the patient's aortic valve. Thus began the search for the perfect prosthetic patient match for aortic valve replacement and the essence of this particular talk. I had three questions that needed understanding when I went on the search for the perfect prosthesis patient match. And those were the authenticity of the manufacturer's labeled valve size and sizer. The second, was there an objective parameter that we could use to define the perfect patient prosthesis match? And last, if we had a perfect match, but the bulk of the prosthesis was too large for the patient's anatomy of their root, was there a procedure that was reproducible, reliable, and safe that we could perform? Well, I went to the University of Michigan Medical School Library search engine to find the answer. I only used peer-reviewed articles published in recognized academic journals. I had two levels of exclusion. The first level, as you can see, was quite simple. The second level placed emphasis on randomized prospective trials, large registry trials with propensity matches or without propensity matches, and meta-analysis articles. I started out with over 6,000 articles, put my two levels of exclusion, and came down to 52 articles, which was the number I was allowed for the manuscript that accompanies this talk. Well, let's go to the first question that we needed to answer. As you know, when we all do aortic valve replacement, we're giving a sizing tool by the manufacturer and a dimensions chart. Well, what does that size really mean, and how does it correlate with the valve that we choose? Well, we're supposed to rely on the manufacturers for their authenticity on a good prosthesis patient match. However, George Christakis from the University of Toronto and Bo Yang from Michigan weren't quite sure that there was a good authenticity for the manufacturer's labeled valve size. And so what they did is they actually measured the valves with sizers. And this is a picture of Dr. Bo Yang in which he implanted valves in patients using the manufacturer's tool and implanted the valve with the labeled valve size corresponding to the tool. Once the valve was implanted, he took sizers, which were a millimeter apart, which were measured as exact, and he started putting them in the openings of these valves. And what he found is there was no correlation with the actual opening area of the valve and the manufacturer's labeled valve size. In fact, they were 5 to 6 millimeters smaller. He then put a table together where he showed if you implanted certain valves according to the labeled valve size and minus 5 to 6 millimeters, which was the true opening area, this was a reduction that you would see in patients, up 36% in a 25 millimeter valve, and this increased dramatically as the size of the valve, labeled valve size, decreased. And so we were grossly undersizing these valves, especially in the smaller valves. And that is why the results are so poor with aortic valve replacement in patients with small annulus size. Well, what are we really measuring, and what is the manufacturer telling us on these charts? If you look at this chart here, they're saying that the internal diameter, which they want us to believe is actually the area, functioning opening area of the valve, is what we need to compare with the patient. But in reality, if you go up and you look at the valve, it's line B. And what that measurement is, the metal portion of the strut of the commissural post. So measuring from the metal portion of the strut from the commissural post from post to post. But there's all this tissue or supporting tissue materials around the strut and the portion of the valve tissue that doesn't open. And this is where Dr. Yang and Dr. Christakis are measuring their 5 to 6 millimeter difference. Well, how does that relate to patients? Well, the Core Valve Research Group studied the relationship of the surgical manufacturer's labeled valve size and sizing tool with the patient's annulus. They took patients from the high-risk and CERTAVI randomized prospective controlled trials of TAVR versus SAVR, and they compared their outcomes for labeled valve size, hemodynamic performance, and incidence of PPM. The surgical valves were sized using the manufacturer's tools. The TAVR valves were sized using CT scan annular dimensions. And we also measured the patient's annulus with CT scan annular dimensions. They then separated the patients into 3 size groups, and they looked for the outcomes. The first thing that they had to make sure occurred was they had to make sure that the mean annular size for all different types and brands of valves for each 3 sizes were equivalent, and they were. And this confirmed that they were comparing their endpoints for each valve type and brand in the same size annulus. What they found was the manufacturer's labeled valve size, their manufacturer's internal diameter, which they said was a functioning opening area, hemodynamic performance, and incidence of PPM were significantly different for each type and brand of valve implanted into the same size patient annulus, demonstrating different size valves, depending on the brand and type, were being implanted in the same size annulus and performing quite differently. This confirmed the inaccuracy of the manufacturer's labeled valve size and sizer. And it showed that preoperative CT scan was probably the most reliable and accurate technique for surgical aortic valve sizing. Well, the Annals of Thoracic Surgery invited a commentary to support this article when it was published, and the commentary emphasized the inconsistencies of the manufacturer's labeled valve size and sizer and recommended using CT scan as their preoperative surgical aortic valve sizing for all future surgical aortic valve replacements. Well, does size of the valve really matter? Once again, the Core Valve group used the same study population, divided the patients in the same size groups, and compared hemodynamic performance, incidence of PPM between TAVR and SAVR in all 3 size groups, and then between SAVR through all 3 size groups. SAVR in the large group compared to the medium group, compared to the small group. And then they compared TAVR in the large to TAVR in the medium and TAVR in the small. So they measured between the 2 types, TAVR and SAVR, for all 3 groups, and among each type in all 3 groups. And what did they find? Well, what they found were, at all time points, and the time points were 3 months, 1 and 2 years, that the mean valve gradient, the effective orifice area, the index effective orifice area were significantly better for TAVR than SAVR. SAVR, and not TAVR, was associated with annular size. And what do you mean by that? That means that SAVR in the large group had much better hemodynamic performance than SAVR in the medium or the small. SAVR in the medium had much better than in the small. However, in the TAVR, there was no difference between the hemodynamic performance and incidence of PPM between the large, the medium, or the small. And the last thing they found was when you combine TAVR and SAVR cohorts, anyone with severe PPM had a significantly negative impact on their all-cause mortality for patients in small annular size. And so that is why in those randomized prospective trials, SAVR did worse than TAVR for the hemodynamics and in the outcome in the small size annulus. And here are some demonstrations. TAVR is in the blue, SAVR is in the red. This is EOA, indexed EOA, mean valve gradient for the small group. And this is the group. This graph on the right shows the difference in the mortality between severe PPM and no PPM, knowing that the majority of this severe PPM is in the surgical group. Well, was there another study giving supportive evidence for this? Yes, there was. It was the partner randomized prospective controlled trials using cohort A. Patients were placed in 3 size groups once again, and small SAVR had a significantly higher incidence of PPM versus TAVR. And there was no difference in the large groups. And this study supports that small SAVR leads to significantly compromised hemodynamic performance and increased incidence of PPM and death. Well, what can we conclude about the valve sizer and manufacturers labeled valve size and size of valves and size of annulus? What we can conclude is that the labeled valve size and measuring tools are inaccurate and misleading, that the opening area of a stented prosthetic valve is 4 to 6 millimeters smaller than the labeled valve size. Annular size and opening area size both matter and must be properly matched for SAVR using preoperative CT scanning for sizing. Smaller annulus and smaller valves have minimal margin for error in prosthesis-patient match. When choosing the size and brand of SAVR valve, understand that the opening area of the valve, which is 4 to 6 millimeters smaller than the manufacturer's labeled valve size, needs to match the CT-derived annular dimension, not the manufacturer's labeled valve size. It's the opening area that needs to match the CT-derived annular dimension. And lastly, if the match between the opening area of your valve and the patient's annular dimensions gives you a valve whose bulk of the supporting structure is larger than the patient's anatomy, then you must do an aortic root enlargement. Well, how about our second objective? Is there a objective parameter that we can determine that we have that match? Well, Jean Dumenil validated the use of echo Doppler flow to correlate the prosthetic valve in vitro area with the in vivo functional effective orifice area divided by the body surface area, known as the index estimated orifice area. And he demonstrated an excellent correlation between the standard and simplified continuity equations and between the in vivo and known in vitro prosthetic valve areas. He saw that these relationships improved when you divided it by the body surface area. So the index effective orifice area is our objective parameter for the prosthetic patient match. To determine whether this would translate clinically, Philippe Pirot performed a study in which he had 61 SAVR patients with an average of 6.2 years after implantation in which he performed TTEs. PPM was determined as present with an effective orifice area index of less than 0.85 centimeters per millimeter, or absent if it was greater than 0.85 centimeters squared per millimeter squared. The follow-up clinical and hemodynamic parameters evaluated were mean valve gradient, prosthetic valve effective orifice area, index effective orifice area, and cardiac index. The clinical parameters were syncope, pulmonary edema, New York Heart Association classification, status. What he found was PPM was present in 52% of these patients. The hemodynamic performance was significantly worse in patients who had PPM as noted by a higher mean valve gradient and lower effective orifice area and index effective orifice area. And this was significant at less than 0.05. The occurrence of syncope, acute pulmonary edema, angina was significantly higher in patients with PPM, and therefore, Peebereau concluded PPM is associated with worse hemodynamic performance and a higher prevalence of adverse clinical reactions. Philip Peebereau later had a second study to support his original study, in which he used the Cohort A randomized prospective controlled partner trial patients. He matched patients with AVR 270, patients with TAVR 304. The data showed that 60% of the patients who underwent a surgical aortic valve had severe PPM, had PPM with 28% having severe PPM, versus TAVR, in which they had 46% of patients with PPM, but only 19% with severe PPM. And as we know, it's severe PPM that's been associated with death in this trial. What they also found was in the aortic annulus diameters less than 20 millimeters, severe PPM developed in 33.7% of SAVR patients and only 19% of TAVR patients. He concluded that severe PPM was an independent predictor of 2-year mortality in SAVR, but not in TAVR. His conclusion was PPM was more frequent and severe in SAVR than TAVR, causing decreased survival and less left ventricular mass regression. Stuart Head from the core valve research team published an article which supports Peebereau. They did the same thing with a core valve randomized trial of high-risk patients, and they showed severe PPM was significantly higher in SAVR than in TAVR, and that in all patients, both TAVR and SAVR, the all-cause mortality in acute kidney injury was significantly greater when the patient had severe PPM, both supporting that severe PPM is deadly in patients with small annular sizes who are being implanted valves who are being downsized because we're not measuring correctly with the manufacturer's labeled valve sizer, and we're putting in opening areas that are 5 to 6 millimeters smaller in those valves versus the patient's already small annular opening. Well, is there other evidence to support the fact that PPM causes poor clinical outcomes in patients? There was a meta-analysis study of over 40,000 patients to determine the impact of PPM on the perioperative mortality and overall mortality. And what they found was the perioperative overall mortality increased in patients with PPM, and severe PPM was associated with increased perioperative and overall mortality, and moderate was with perioperative mortality, but not overall mortality. And so once again, severe PPM correlates with poorer outcomes than not PPM. This study group concluded that PPM should be avoided in patients at all costs. A second meta-analysis of 34 studies comprised 27,000 patients, defining PPM by VARC-3 criteria, concluded the severity of PPM increased with the incidence of all-cause the severity of PPM increased the incidence of all-cause mortality, as well as cardiac-related death, and they recommended the avoidance of PPM. So what do we know about our parameter? Well, we do have an actual parameter that can help us define prosthetic patient match, and that was Dumenel's effective orifice area index. This was verified or sanctioned by VARC-3. We do know that PPM occurs significantly higher rate in SAVR than TAVR. PPM is significantly associated with annular size and valve size in SAVR, especially in the small and medium size. The smaller the annular size and valve size, the higher likelihood of severe PPM in SAVR. PPM is associated with mortality and poor hemodynamic performance, especially in the smaller size SAVR valves. Severity of PPM increases the incidence of all-cause mortality and perioperative mortality. The reason PPM is greater for SAVR than TAVR is secondary to the inaccurate manufacturer's labeled valve size and sizing tool, which undersizes the opening area of SAVR about 5 to 6 millimeters in comparison to TAVR, which uses CT scan derived annular size and matches the TAVR opening area to the CT scan opening area. Therefore, we need to use CT derived annular dimensions for our preoperative sizing and know that the valve that we want has to have an opening area 5 to 6 millimeters smaller than the manufacturer's labeled valve size. Well, how about root enlargement? Do we have a procedure that can we do safely and reliably? Because we all know that if we're going to have a 5 to 6 millimeter downsize on the manufacturer's labeled valve size, that we're going to be putting valves with larger bulk to get that match. And so we're going to need to be performing many more root enlargements. Well, what is a normal valve annulus anyway? Well, TAPS, published in the Journal of Thoracic and Cardiovascular Surgery in the year 2000, that the average male annulus in 2,214 patient studies was 23 millimeters. In the actual valve annulus, the mean in females in over 1,100 patients was 21 millimeters. So what does that mean? Does that mean if we put a valve with a 21 millimeter size that we're going to solve our problem in a female patient? Absolutely not. Why is that? Because when you look at the angular measurement by Christophus and Yang, the actual opening area is about 15 millimeters. So basically what you're doing is you're taking this patient from 21 millimeters to 15 millimeters. And that's why women in all the studies, especially those with a smaller annular size, have significantly poorer outcomes, because the smaller you get in your annulus, that 5 to 6 millimeters proportionally to how you're downsizing is more significant, as we saw in Yang's chart. And this leads to severe PPM, which leads to higher mortality. So you have to do enlargements in a large majority of women who have these small annular sizes. The same goes for men. If you put a 23 millimeter valve in a male who has a 23 millimeter annulus, you're going to be sticking a valve in there that has a 17 millimeter opening area, once again, causing severe downsizing. So according to Yang, it's 36% for a 25 millimeter, 52 for 23, and minus 56 for a 21 annulus. So really, what is the annulus that we're measuring on the CT scan? Is it the semilunar crown attachments that we use and call an annulus for our surgical aortic valve replacements? Not really. What it is the horizontal basilar plane at the nadir of the 3 semilunar attachments to the left ventricular outflow. It's this green line down there. And so basically, the valve is like a crown being put on a head. We actually fit the crown to the basilar ring or basilar annulus. And then depending on how ornate the crown is or how much bulk the valve has, somehow we have to accommodate this within the annulus. And so therefore, and when we're putting in a valve whose opening area matches that of the basal ring, we're going to have a bigger, bulkier crown here, and we're going to have to accommodate it with a root enlargement. Well, what kind of procedures are there? There are 3 procedures. The first is a Nix procedure. It's the most simple of the enlargements, and it's just an incision down the non-coronary sinus from the aortotomy vertically down to the mitral fibrosa. You put a triangular patch in, and you can enlarge the bulk of the valve one manufacturer's labeled valve size. The second is the Manugian, and you cut down the left, the left non-post. You take it through the mitral fibrosa into the anterior mitral leaflet and into the left atrium. And when you patch this up, if this is your horizontal plane here, you use this portion of the patch, and you can much more easily enlarge this one, maybe two manufactured valve sizes. Well, what are the results with the Manugian in the NICs? Most of the literature of aortic root enlargement is all Manugian and NICs. Well, there are several meta-analyses out there. There's one that shows 10 articles because there's no randomized trial for this. So we have to use meta-analysis or a large propensity registry match. The first meta-analysis showed 10 articles, 13,000 patients. In those groups, they divided it into AVR plus root enlargement. They found that on average, there were 21% of the patients had root enlargement. What they found was perioperative mortality was significantly higher in patients who had AVR enlargement versus AVR. However, if they separated it out into isolated AVR versus isolated AVR root enlargement, there was no significant difference in perioperative or follow-up mortality. What they did find in support of AVR root enlargement was there was an overall lower risk of severe PPM, and there was a higher overall effective orifice area and hemodynamic performance. And as we know, in the long-term PPM, it's going to be reflected in mortality. A second random effects meta-analysis of 8,000 patients showed no difference in early mortality in the whole group of AVR versus AVR plus root enlargement. This is not just isolated, this is a whole cohort of patients. And they found the risk of moderate and severe PPM was lower in patients with AVR root enlargement. They saw no difference in late mortality in this group either. There was a good multi-center propensity score match cohort analysis undertaken to determine early and late mortality. There was over 16,000 patients from 11 institutions, and they used one-to-one propensity score matching and had 809 matches to study. What they found was there was no difference in the 30-day mortality between AVR and AVR plus root enlargement for the entire cohort, not just isolated, but the entire cohort. They also saw that late mortality over 8 years was similar. When they did a sensitivity analysis of AVR plus CABG versus AVR plus CABG plus root enlargement, there was no difference in mortality or major morbidity, except for reoperation for bleeding was higher in the AVR RE CABG group. So what can we conclude about this? We can conclude that it's a safe, reliable, and reproducible procedure, and we should think more about root enlargement. Well, how about the Yang enlargement? The limitations of the NICs and the Manugian is you can maybe enlarge at 1 to 2 valve sizes. But as we know, the valves are 5 to 6 millimeters downsized. That may be 3 valve sizes, or consistently 2 to 4 valve sizes. So we need something that'll give us a larger base for enlargement to put larger valves in. Well, the Y-incision gives us that opportunity. The Y-incision is a vertical incision down the left non-post, but instead of taking it straight down, you excise parallel to the semilunar annulus to the left and non-annulus, and this opens up the mitral fibrosa. You don't have to enter the left atrium. You don't have to go down the mitral valve. Instead of having a pointed triangle-shaped patch, you now have a larger rectangular patch, using the mitral fibrosa and the semilunar annulus of the left and non-cusps. And this gives you a big patch. You then use the remaining portion of the semilunar annulus and then augment this area by coming up on the valve, coming up on the patch as high as you need to incorporate the bulk of the valve whose opening area matches the basilar plane and the opening area of the patient. And as this post-op CT scan shows, you can put a 29 magna E's inside a basilar plane of 23.7. This is a post-operative CT scan on a patient who had an annulus measured at basal plane of 23 and a 29 valve was implanted. And once again, when you measured the effective orifice area of that, it's 23 millimeters. So this supports what Yang and Christakis were saying, is that the opening area of that valve is clearly 6 millimeters smaller than the manufacturer's labeled valve size. Well, what do we know about? Is it safe? Is it reliable? Is it reproducible? Well, we know that Yang has published on this, and this hasn't been around as long as the other two enlargement procedures, but we know Yang published on this. And so in his hands, it's quite safe. Is it reliable or reproducible? We have to give it some time and allow other excellent surgeons to take this procedure on, go through a learning curve, and then we'll get data just like we did on the other two. But Yang reported on his first 50 consecutive patients. The mean age was 65, 70% were female, no surprise because they get downsized the most. 26 had previous surgery, and those were mostly redos for patients who had PPM from their previous valve implanted, and 66% were isolated AVR. Preoperative mean gradient was in the 40s, and the native aortic annular size was 21. There was one stroke in these patients, no operative deaths, no operative renal failure requiring permanent dialysis, no mediastinitis or reoperations for bleeding. When you look at the chart of the valves that Dr. Yang implanted, he had 123, and this was in a patient who measured 19 millimeters, and he had a 925s, 1327s, and 29 valves. You can see the slope of this increased as the numbers increase. And here you have annular size, manufacturer's labeled valve size, slope of the line as his experience increased and his confidence increased, the larger valves that he would implant and the bigger upsizing he would perform. And this is the hemodynamics. These hemodynamics look similar to TAVR hemodynamics postoperatively with a nice single-digit mean valve gradient and a nice effective orifice area over 2, which is consistent out 12 months. Well, what are the implications of preoperative TAVR CTA for SAVR? Fukuhara had a publication, and his main aim was to evaluate the utility of TAVR CTA and its clinical implications in patients undergoing SAVR. And he looked at his institution. He wanted to see what was the incidence of using a CTA preoperatively, and what was the incidence of doing a root enlargement at his institution. And as you can see, from 2014 through 2022, there was a marked increase in the number of CTAs performed preoperatively, and there was a marked increase, similar in parallel, in the number of root enlargements, because based on that preoperative size, you had to enlarge to get a prosthesis-patient match. He studied 373 patients using pre-op CT scan. Median age 68, 37% were female, 36 had bicuspid valves. The SAVR implant techniques were 64% of the patients had no enlargement, 19 had the Nix Manugian, and 16 had the Y-incision. The corresponding median implanted valve sizes were 25 in the patient group that needed no root enlargement or didn't get a root enlargement, 23 in the Menugian nicks, and 27 in the Y-incision. The corresponding incidence of PPM was 35% in the patients with no root enlargement, 43 in the patients with a Menugian or nicks, and 6.5 in the patients with the Yang. You can say, wow, they did an enlargement and it's worse than not enlargement. Why would you enlarge? Well, these patients had very small annuli, and without the enlargement, these numbers would be higher. And in the group with a non-root enlargement, there were patients who measured 29 and you put a 29 in. So just think how bad this group would be without an enlargement. So the next thing he did was he took those patients who had a CT and a SAVR implanted and used a sizing charts for TAVR and said, what size self-expanding, what size balloon TAVR would go in those patients? He then looked at the IFU for EOA for both of those TAVRs for the patients and calculated and determined the incidence of PPM. What he found was significant PPM occurred in TAVR with a self-expanding valve and 41% in the balloon expandable device. In a subgroup analysis of SAVR versus TAVR, the Y-root enlargement was the only group, surgical group, that had an incidence of PPM smaller than a self-expanding TAVR valve. He concluded that, and this is a chart which shows this, theoretical TAVR, SAVR, no root enlargement, significantly more PPM surgical group. The standard root enlargement, Menugian and nicks, significantly more PPM than a TAVR. And in the Y-incision, significantly less PPM in the SAVR than the TAVR. So Fukuhara included that the manufacturer's labeled valve size tool for SAVR sizing gave you an implanted valve whose opening area was much smaller than the valve that you should be implanting, and that we should be using CT annular dimensions as our valve annulus and matching the opening area of our prosthetic valve to that CT annular dimension and not trying to use the manufacturer's labeled size, valve size. He noted the risk of relevant PPM and the necessity for aggressive root enlargement can be predicted utilizing that CT scan. And this may have a long-term favorable implication on young patients with lifetime management. If we're going to be putting valves in young patients, we want to put valves that last longer and function just as good as a TAVR. And then he said, SAVR, using the novel Y-root enlargement technique, outperforms even a self-expandable TAVR with regard to PPM. And it allows a much better foundation for future TAV and TAV than you would if you didn't enlarge. A lot of times when you try to do TAV and TAV in these small valves, you get very poor results with high PPM because you are putting the TAV in a small construct. So how does this, we're talking about TAVR versus SAVR, we're talking about PPM, we're talking about durability. Is there a correlation between the sizes of these valves and TAV and SAV in these trials as far as valve degeneration is concerned? Well, a trial has been performed which will give us evidence, and that was by the core valve group, which they looked at the 5-year incidence of bioprosthetic valve performance in patients randomized between surgery and TAVR. And they wanted to evaluate the incidence, outcomes, and predictions of long-term valve performance as assessed by bioprosthetic valve degeneration. And what they found was the 5-year bioprosthetic valve degeneration for TAVR was 8.1% and was for surgery was 12.6%, significant difference. And when you looked at it, it wasn't structural valve degeneration requiring reoperation as we commonly use in surgery. It was due to non-structural valve deterioration as defined by VARC3 criteria. The large majority of these patients had non-structural valve degeneration. What does that mean? Well, that's defined as either significant leak or a mean valve gradient post-procedure of greater than 20 millimeters of mercury, or one that increases from the first post-op echo to greater than 20 millimeters of mercury, or one that doubles over time. And as you can see, we know we don't have much aortic insufficiency or valve leak because the randomized prospective trial shows surgery outclasses TAVR in that category. So it's all hemodynamic performance. And it's all due to us undersizing the valves. So does bioprosthetic valve degeneration impact the patient? We don't have to reoperate on these patients. But what they found was when you have a bioprosthetic valve degeneration, you have a higher incidence or higher propensity for all-cause mortality, cardiovascular mortality, hospitalization, whether you have a TAVR or a SAVR. It doesn't matter. So you want to avoid bioprosthetic valve degeneration, especially non-structural, due to undersizing our valves. So what are our overall review conclusions for this whole study or this whole journey to investigate how we're doing in our pursuit of the Holy Grail in aortic valve surgery, the perfect prosthesis-patient match? What did we learn over time, and how are we improving, and what can we do better? Well, we learned that the manufacturer's labeled valve size is misleading and inaccurate with respect to the opening area of the prosthesis. We learned that according to Yang and Christakis, the opening area of the prosthetic valve is 3 to 6 millimeters smaller than the manufacturer's labeled valve size. We learned that sizing using the labeled valve size will result in the implantation of a valve with an opening area 3 to 6 millimeters smaller than is required. So we can't match the labeled valve size to the patient's annulus. CT scan derived annular size and the true opening area of the prosthetic valve are the two measurements that need to be matched for the best hemodynamic and clinical outcomes. Implantation of a SAVR using the labeled valve size tool and into a small annulus results into a significantly lower EOA, indexed EOA, and a higher mean valve gradient and incidence of PPM, resulting in worse clinical outcomes than TAVR because we are undersizing using the manufacturer's tools. We're undersizing 3 to 6 millimeters. And in the small and medium annulus, this is of significance. Margin of error for sizing is more critical in small annulus. We talked about that. Look at Yang's chart. Based on the work of the core valve study group and Fukuhara, preoperative CT scans should be used as a signing and planning tool for SAVR, since it allows for both annular and root cavity anatomy and will help us predict preoperatively whether we need to do a root enlargement. The best method to avoid PPM is to match the CT scan derived dimensions to the opening area of the prosthetic valve of choice. The average female annulus is 21 millimeters, male is 23. According to Yang's table of measured functional internal diameters, which we call opening area, if the CT scan derived annulus internal diameter or functional opening area is less than 20 millimeters, implant a valve with a labeled valve size of 25 millimeters. If the CT scan annular dimensions is 21 to 23 millimeters, implant a valve with a labeled valve size 27 to 29 millimeters, depending on the patient's size and the root anatomy. If the CT diameter is greater than 23, implant a valve with a labeled valve size of 29 millimeters. This will give us the perfect match. We also know that the percentage of AVR and Y enlargement should increase over time. Do not oversize your SAVR valve greater than matching the SAVR opening area to the CT-derived annular dimensions because you don't want to compromise coronary access for future PCI. Too much of a good thing is not good at all. All you have to do is do that match. Don't oversize it. Don't ever compromise access to the coronary arteries. And the last thing is to compete with TAVR for hemodynamic performance, incidence of PPM, prosthetic valve degeneration, and clinical outcomes in patients with small and medium annulus, less than 26 millimeters. Surgeons must become comfortable with the Y enlargement procedure. Well, I hope from this review, you learned some valuable information, appreciated the progress made along the path, and the contributions of dedicated scientists and clinicians over the past 55 years since Dr. Rahimtoola introduced the concept of prosthesis-patient match on the pursuit of the Holy Grail in aortic valve replacement surgery. Thank you very much.